I'm Udho Thadani from University of Oklahoma VA Medical Center, and my topic of discussion today was stable angina pectoris, but in which we should take into consideration patients' blood pressure, heart rate, and comorbidities. And the reason I picked up this topic because the guidelines are well established, but there's really poor data even in the guidelines to recommend what a physician should do when you've got issues with these aspects of patient. We know that patients with stable angina pectoris, 60–70% will have coronary artery disease, and the guidelines are very good for that. What we really still don't know in the patients who do not have coronary artery disease but still have angina, and the guidelines are a bit ambiguous and not really clear how to manage these patients. So that was highlighted in the talk. And specifically, if you don't have coronary disease, should you be using aspirin or statin on all these patients? Is really not data driven. And point two, I try to make that all the guidelines are based on that medical treatment is equivalent to revascularization or based on knowing coronary anatomy, because all the patients had a coronary angiogram, and if they in the trials, and if they had left main disease, they were excluded. So I think there is some issue which that means you have to subject all the patients to coronary angio before you apply the guidelines. So that's another point. But more importantly, the guidelines are very reasonable when you use aspirin, low dose aspirin, statin, regular exercise, stopping smoking, best bang for the money to improve heart outcomes. But as far as anti-anginal treatment is concerned, they're a bit not clear-cut, especially in a group of patients who have low heart rate, low blood pressure, severe COPD, because those patients are all not included in the trials. So what I try to highlight that when we see a patient, we take those into consideration before we use the drugs, and the drugs are different. Some affect the heart rate, some affect the blood pressure, some affect both, and others have no effects on heart rate or blood pressure. So my feeling was, although not guideline driven, we can use medications appropriately for individual patient. For example, patient has a normal blood pressure, normal heart rate, no COPD, you can use any drug. Guidelines say use drug A versus B. I don't think it's data driven. So one could use a beta blocker, a calcium channel blocker, nitrate, or nalazine, ivabradine not approved, or for that patient. On the other hand, a patient who has low blood pressure, you probably don't want to use a beta blocker or a CCB, but you might pick up drugs which are neutral on these, like nalazine, perhaps ivabradine and trimetrazidine. On the other hand, if a patient has high blood pressure, then you want to use drugs which affect blood pressure as well as heart angina, because otherwise using drugs which may affect angina but no blood pressure. So you might pick up a calcium channel blocker or a beta blocker. Then there are a group of patients with atrial fibrillation in whom I think you want to pick up a beta blocker or a non-dihydropyridine calcium channel blocker because you want to block the AV node. Otherwise, a drug like ronalazine, ivabradine are not going to be effective. Then you have patients who have severe COPD or asthma, and we have no clue which drug to use, although guidelines make some recommendation, but they're not data driven. And in that patient, perhaps you want to pick up a long-acting nitrate, drugs which are neutral on the pulmonary function. You don't want to use a beta blocker, but you might use a CCB or ronalazine or ivabradine. So I think these are the issues which we face every day, and I think trials are needed in this subgroup of patients, and hopefully younger investigators and smaller trials can look at this subspecific population to find out which is the best regimen for them. So I think that was more of a criticism of the published trial and more of how we deal with patients and what is more needed at the present time.